Title: Assessment of Autism Spectrum Disorder with Children Who Are Deaf, Hard of Hearing, Part 1. Deborah Mood, PhD, Colorado School for the Deaf and the Blind. Split screen: the sign language interpreter and our presenter, Deborah Mood, licensed psychologist, who is sitting in front of a solid background. Captions are below on screen.
Hi, my name is Dr. Debbie Mood. I'm a licensed psychologist, and today I'm here to talk to you about assessment of autism spectrum disorder with children who are deaf and hard of hearing. To give you a little bit of information about my background, I'm a psychologist, and I have specialized training in working with children who are deaf and hard of hearing with a degree in school psychology from Gallaudet University, and then I later pursued a PhD in school psychology as well. And in my current work capacity, I work at a local children's hospital where I work with children who have a wide variety of developmental disabilities, including autism, as well as with children who are deaf and hard of hearing. So today, what I hope to talk about is what are the symptoms of autism and how do they present specifically among children who are deaf and hard of hearing. Today we'll be talking about symptoms as they might present in children who have reduced hearing who use an auditory verbal approach, as well as in children who use a sign communication modality, and how the symptoms of autism can present both similarly and differently among children who are deaf and hard of hearing. We're also going to talk about a little bit about how do we assess for autism with children who are deaf and hard of hearing. So many of you may have already seen the broadcast by Dr. Angie Lawson, where she reviewed the criteria for a diagnosis of autism. And I'll refer you to that presentation for more in-depth information about the specific criteria in general, and for information about how a medical diagnosis of autism differs from an educational classification of autism. Just to briefly review those diagnostic criteria that physicians and psychologists use for diagnosing an autism spectrum disorder, we use a manual called the DSM-V, the Diagnostic Statistical Manual, 5th edition. And the criteria that's outlined in that DSM-V manual indicates that for an individual to be given a diagnosis of autism, they have to meet specific criteria. So they have to have difficulties with social communication and social interaction across several contexts that are not just explained by either a sensory difference, like a vision or hearing difference, or by a general developmental delay. The criteria also indicates that those areas of social communication that we're looking for that might be different for children who have an autism spectrum disorder are specifically difficulties with social emotional reciprocity, difficulties with nonverbal communicative behaviors, and difficulties developing and maintaining developmentally appropriate relationships, so relative to their developmental age rather than their chronological age in the situation where you have children who have some kind of developmental delay. We're going to talk more specifically about what those look like, what those symptoms look like in hearing children with autism, how they might present in children who are deaf and hard of hearing, and how that differs from symptoms that might appear to be related to the child's reduced hearing. The next DSM-V criteria that has to be met is at least two the following have to be two difficulties with restricted or repetitive patterns of behavior have to be met. So the potential options there would be stereotyped or repetitive speech, repetitive motor movements, and we'll talk more about what stereotyped language means. Excessive adherence to routines or ritualized patterns of behavior, highly restricted, fixated interests, or interests that seem abnormal in terms of the intensity, or things that seem unusual for the child's age. And a newer criteria that was added with this revision of the DSM-V are hyper-erlypo-reactivity to sensory input. And we'll talk more about what those mean in a minute. So the other stipulation in the guidelines in the DSM-V are that the symptoms have to be present from early childhood. However, they may not become readily apparent to everybody until, in some situations, until the child is in a social context where their abilities to manage the social demands are unable to meet the expectations in that context. The other criteria is that the symptoms have to have a functional impact for the child. So that's the diagnostic criteria that we use for assessing for an autism spectrum disorder, but the criteria itself is kind of vague and ambiguous unless you really understand what those symptoms mean. And I also want to provide a broader context for understanding autism. When we talk about autism, those DSM-V criteria are what we consider the core difficulties. However, how autism can present varies very much across children. So we often say if you've met one child with autism, you've met one child with autism, because children can meet the diagnostic criteria for autism in a variety of different ways as long as they have those core difficulties. Some of the things that contribute to how children with autism might look differently are what we call moderating features, so features that impact how those symptoms present. An example of that would be how a child who was minimally verbal or who had minimal communication in any modality, whether that's sign language or spoken language, might look compared to a child who had very good communication skills. Another example of a moderator would be their cognitive abilities. So a child who had an intellectual disability in addition to autism might look very different than a child who had average to an above average IQ in terms of how the specific symptoms present. Then we'll talk about also some of the things that can really impact a child with autism are some of these associated features. So if we pull out and we look at the broad concept and the big picture of what an autism spectrum disorder, how it might present, again, we have those core difficulties with social difficulties, the social communication difficulties, and those repetitive behaviors. But among children with autism, we often see patterns of children who are more likely to have associated difficulties. Those can include specific medical issues, such as GI issues, gastrointestinal dysfunction, feeding difficulties, sensitivities to particular types of food. We also often see children who have sleep difficulties, and as we all know, if children are not sleeping well, or if any of us are not sleeping well, that can have a huge impact on the child's behavior. Some of the other things that can manifest later or can be present with an autism spectrum disorder are the presence of other neurological concerns, such as seizures. And seizures can have a definite impact on the child's functioning. So those are all, even though we talk about the core features that we look for in diagnosing autism, all of these other things are really important to look at too, because they have an impact on the child's quality of life and how they function. Oftentimes when teachers or parents are concerned about behaviors, sometimes we can approach that from a behavioral standpoint, but often we also need to approach it from a medical standpoint to really have success in managing that behavior. So another associated difficulty that we sometimes see, especially as children with an autism spectrum disorder approach adolescence, is the onset of an anxiety disorder and sometimes a mood disorder. And again, those are things that are also important to screen for and to consider in your diagnosis, because they have a big impact on the child's quality of life and their functioning. So any assessment or diagnosis of autism should also include a developmental interview and clinical interview that looks at those related areas of difficulty. Why is it so important to understand how autism presents in children who are deaf and hard of hearing? We have some information that suggests that there might be higher rates of an autism spectrum disorder among children who are deaf and hard of hearing. In Dr. Angie Lawson's presentation, she discusses that quite a bit, and so I'll leave that topic for today. But one of the things that we do know is that children who are deaf and hard of hearing tend to be diagnosed later than hearing children with an autism spectrum disorder. And particularly when we're talking about autism, we know that earlier intervention is so critical in contributing to better outcomes. And so it's really important to understand how autism looks and presents in children who are deaf and hard of hearing, so that we can make sure that if they have additional needs that are related to autism, that we can intervene early and change those developmental outcomes. So now I'm going to talk about the symptoms of autism, how they present in hearing children who have autism, and we'll talk about how some of these behaviors might be confused as being symptoms of autism among children who are actually typically developing, children with reduced hearing. And then we'll talk about how they specifically look in children who are deaf and hard of hearing who also have autism. So how do we distinguish that? For example, when we talk about difficulties in communication, hearing children with autism often have very specific communication difficulties. They often have difficulty integrating their eye contact with their spoken or signed communication if they're using sign communication. They have differences in how they use eye contact. They also have difficulty integrating their spoken communication with gestures. So most of the time when we talk, we support our communication with gestures, and especially in early childhood, that's a skill that young children rely on quite a bit to make their communication understood. And children with autism who are hearing have difficulty with this. They also often have difficulty regulating how they use other nonverbal aspects of communication. So their facial expressions may not match the situation. This can be confusing to people because if we see a child who laughs when someone gets hurt, we get upset that they're laughing that someone's hurt. But for a child with autism, they may have difficulty using those facial expressions and matching the situation. Oftentimes you'll see hearing children with autism who have difficulty understanding their peers' nonverbal cues. So what that can look like is children who don't recognize when their peers are making a face or a gesture that they don't want to play with them, or that the child is doing a behavior that's upsetting to the other child. And so those children with autism will sometimes persist in doing that behavior that the child is trying to nonverbally communicate that they don't like. So in typically developing children with deaf and hard of hearing, a lot of those difficulties are not the norm, right? So children who are typically developing who are deaf and hard of hearing generally have appropriate eye contact. You'll sometimes see children who are typically developing who are deaf and hard of hearing who might purposely avoid eye contact, especially if that's their primary means of communication. But otherwise, especially when they're making a request themselves for something, they usually direct their eye contact with the person that they're trying to communicate. Even for children who use sign language to communicate, we know that they use both formal signs, that are the signs that are used in their environment, that are formally shared among the community for communicating, but they also use descriptive gestures that might be spontaneous ways of using those ASL classifiers in the case of children who are signing using American Sign Language. Children who are deaf and hard of hearing often use a wide range of facial expressions in the absence of an autism spectrum disorder. In fact, facial expressions are part of some of the grammatical features of American Sign Language, and so they're necessary for children learning the language and using the language to use them appropriately. Having said that, children who are deaf and hard of hearing sometimes have difficulty acquiring English and spoken English in very specific ways. So there are specific difficulties that we know children with reduced hearing might have in terms of vocabulary, grammar. Depending on their degree of hearing loss, they might miss particular morphemes in the spoken language. Children who are deaf and hard of hearing may misunderstand or not fully understand idiomatic expressions that we use if they haven't been exposed to those. So those are differences in their language that we might see even among children who are typically developing, who are deaf and hard of hearing. But with intervention, those skills typically improve. Generally speaking, the language progression in children who are deaf and hard of hearing who are typically developing is one that follows an expected pattern. There might be those differences in how they acquire a language, depending on the modality of their communication that I just described. But generally, with intervention, they make progress and use that language spontaneously across a variety of contexts. Whereas in autism, the trajectory of how the child learns language can differ in very specific ways. For children who are deaf and hard of hearing, who have an autism spectrum disorder, the way that they acquire language might differ in ways that are more similar to children with autism than to children who are deaf and hard of hearing. So typically developing children who are deaf and hard of hearing before they establish the ability to use spoken words, if that's their communication modality, or signs, if that's their communication modality, tend to communicate by using eye contact and gestures. And so in typical development for children who are deaf and hard of hearing, those things are not really impacted by their reduced hearing. But for children who are deaf and hard of hearing who have autism, we often see that those children have difficulty, again, making eye contact. They have difficulty using gestures. Some common early gestures that might be an example of that are pointing. Pointing is a really important skill that comes in pretty early. Usually by 12 to 18 months, we expect children to be pointing. And pointing not just to request something, like pointing to something over there that they want and vocalizing or signing that they want it, but pointing to things that they want and looking back to the person that they're trying to communicate. Also, not just pointing for things that they want, because sometimes kids have been reinforced to do that, but also pointing for the purpose, this very social purpose of sharing interest in something. So pointing when they see something new in the sky, like a hot air balloon or an airplane. Pointing when anything stands out to them as being interesting. And again, directing that and looking at the person that they're with, whether that's a caregiver or a teacher or a friend. Children who are deaf and hard of hearing who have an autism spectrum disorder sometimes fail to use those early communicative gestures in addition to pointing. One of my favorite ones for young kids is this one for where is it? Or the other ones that we see like up or come here. Those are some early gestures that we expect to come in between definitely by the first and second year of life if the child is mobile. Some other ways that we see language look differently for children who are deaf and hard of hearing who have autism is differences in how they use their speech, what we call the prosody of their speech if they're using spoken communication, or their sign. So you might see children who are deaf and hard of hearing who have autism who are not using the correct signing space, the culturally appropriate signing space. Sometimes they're signing down here to themselves, but they're not orienting their signing for the purposes of communicating with other people. If they're using speech, you might see children who have kind of a monotone intonation in their speech. Again, even for children who have some kind of reduced hearing, that can have an impact on the quality of their speech sometimes, or the way that they produce sounds, and sometimes it has a variable impact in how they're speaking. But generally, they're still able to recognize and understand how others in their environment are shifting their spoken language to ask a question, for example, with a rising intonation at the end, rather than having a monotone tone of voice in asking a question or expressing excitement. One of the big red flags that we look at is as children are acquiring language, are they starting to use it spontaneously? That is, do they only use it in the situations where you've taught them to ask for more, like more food, because you've worked very hard at teaching them the sign for more at the dinner table or during snack time? But then do they have difficulty using that same sign more to ask for more of an activity? or more of social interaction that they want. So sometimes we see children who are deaf and hard of hearing who have autism who have difficulty generalizing the language as they're learning it across different contexts and across different people. Whereas for typically developing children who are deaf and hard of hearing, they're generally able to do that. For older children who are deaf and hard of hearing, some of the ways that we see differences in their communication behavior present might be difficulty kind of understanding what we call the pragmatics of communication, the social use of language. So they might have difficulty understanding how to enter a conversation with other people who are signing, or how to leave a conversation with other people who are signing, or how to appropriately get someone's attention in ways that are consistent with deaf cultural norms for that. I'm going to talk quite a bit about this aspect of how language might look differently for children who are deaf and hard of hearing who have autism. It's one of the few areas where we do have a little bit of emerging research in this area. And there are differences in how these communication features can present in a spoken language versus a signed language that I think are important. One thing that I do want to emphasize in relation to this point, that children who are deaf and hard of hearing who might have an autism spectrum disorder sometimes have differences in how they're communicating, is that we should never assume that a child who's having difficulty acquiring a language in whatever modality that is, whether it's through spoken or sign language, is having that difficulty just because of the modality itself, or because they may not have as much exposure, for example, to sign language in their home environment with parents who are learning sign language. If a child is having difficulty acquiring language at the rate that we would, as professionals in deafness, would expect, then we should look further and consider whether there might be something like an autism spectrum disorder or another developmental difference that might be contributing to that. I also want to emphasize that although language deficits or delays are not one of the core symptoms that we described in terms of the diagnostic criteria for autism, so that is that a child can have a diagnosis of autism and their receptive and expressive language can actually be age appropriate, but their social use of language can be very different. So having said that, even though it's not a core deficit associated with autism, language delays are very commonly found among children who have an autism spectrum disorder. So in Dr. Aaron Shields' study of children who are deaf with deaf parents who have an additional diagnosis of an autism spectrum disorder, even though those children had exposure to native language models of ASL, about 1/3 of the children who were those children who had a diagnosis of autism had limited language in sign language. On average, their receptive ASL skills also were significantly below their typically developing deaf and hard of hearing peers. So that suggests that even though we use sign language sometimes as an intervention with hearing children who are minimally verbal, even though we could expect them to have auditory access to spoken communication, exposure to sign language itself is unlikely to be enough of an intervention in and of itself to be a silver bullet that's going to remediate the child's communication difficulties. And instead, we need to think about incorporating very specific strategies to teach the social aspects of communication for children who we suspect might have an autism spectrum disorder. In some cases, this means that we need a different approach, such as using assistive communication devices. I want to talk about how the communication features of autism can present both similarly and slightly differently in spoken and sign modalities. So some of the things that we see that are the same are that in both spoken speech and sign language, we see something called echolalia, which is a common symptom of autism. And echolalia refers to children who repeat back what is signed or spoken to them. Both clinically and in the literature, we see evidence of that in hearing children with autism who use spoken communication, in children who are deaf and hard of hearing who communicate using spoken language, and also in children who communicate using a sign modality. So these are the children who might be repeating back in sign or spoken language what you say to them in a way that feels odd. Repeating what you say might be, in early stages of acquiring language, more common, because it can be a mechanism for that child to learn how to produce the new word or the new sign. But as children acquire and have combined words and signs, we would expect echolalia to disappear as they acquire more language. Another thing that we can see in spoken language and sign language is something called idiosyncratic language. And that's a big fancy way of referring to children who use words in ways that are unique to them. And so in spoken language, this can be a variety of different things. It could be children who refer to somebody by their age, or by where they met them, or by the car that they drive. So I've worked with children who called me Miss Debbie, Toyota Camry 1999, back when I was driving that car. I've also seen this in sign language. So sometimes I've seen some children who refer to their grandparents or a grandparent by the sign for McDonald's because they associate their grandfathers taking them to McDonald's. You might also see this in sign language as a persistent use of a particular gesture, even though it's not the formal sign that's being taught or used with the child. So a child who persists in signing red, even though for ketchup, even though everybody around them is signing ketchup or something different, depending on your regional sign for that. But again, it's that idea of when presented with a formal sign for that, the child is still persisting and using this gesture or sign or word that they've associated with a particular situation or person. We know that children with an autism spectrum disorder sometimes have something called pronoun confusion, where they specifically confuse the pronouns you and I. So confusing he and she and things like that is part of a typical developmental trajectory, but specifically confusing you and I is very unique for children who are deaf and hard of hearing, who are communicating in a spoken modality in the absence of an additional vision impairment. I should clarify that much of what we're talking about today actually is very specific to children who are deaf and hard of hearing who don't have an additional vision impairment, because their developmental trajectory in the acquisition of these early social communication skills is different. So for children who communicate using a spoken language, an example of you and I pronoun confusion might be, you might say to the child, do you want a cookie? And they repeat back, you want cookie, instead of I want cookie. This involves a difference in perspective taking that's necessary in order to switch the pronoun use correctly. Dr. Aaron Shield is a linguist who has looked at language features of children with autism who are deaf and hard of hearing. And in his sample of these children, he's seen something called pronoun avoidance. So rather than using what we would use in sign language, which would be pointing to refer to the person, children often avoid using that point to reference a person. He showed them a picture of himself and he asked them, who is this? And children who had autism were far more likely to sign boy or man or fingerspell his name rather than pointing to him when he was in the room showing them the picture. So children who communicate using a sign modality might be likely to avoid using pronouns. One of the other things that Dr. Shields saw in his sample of children who had autism, who were native ASL users, was a tendency to reverse their palms in their signing. Where you might sign the alphabet outward, the children were reversing their palms and signing it to themselves, reflecting difficulty understanding that they had to orient that outward for somebody else's perspective and instead signing it to themselves the way that they perceived it. So there are several theories about why that might be, but one of them is that, again, it reflects this difference with their ability to shift perspective taking, to take on an understanding of the other person's perspective, and we can see how that could impact their acquisition of sign language. This is something that we also see in hearing children with autism. You might see early on children who wave this way when we're working on teaching them to wave, again reflecting that difficulty with perspective taking, perhaps. Some of the other differences that we might see in language features in a sign language are difficulties in the deaf child's use of facial grammar for ASL. This is something that is still being researched. Tanya Denmark in Great Britain has been looking at this, and we're not sure yet whether difficulty in using that difficulty in understanding nonverbal aspects of communication will impact a deaf child with autism's ability to acquire those ASL grammatical facial features.
Title: Presentation continued at Assessment of Autism Spectrum Disorder with Children Who Are Deaf, Hard of Hearing, Part 2. Deborah Mood, PhD, Colorado School for the Deaf and the Blind. A production of Outreach Programs, Colorado School for the Deaf and the Blind, 33 North Institute Street, Colorado Springs, Colorado 80903. Telephone 719-578-2100. www.csdb.org. Graphic: the CSDB logo.